you'll receive. And I'll just hand over to Rachel now.
Hello, hi. I am just going to get up the presentation here. Bear with me for a moment. Okay, great. So thanks for that, Lily. My name is Rachel Retzler, as Lily mentioned, and I work at Evelina on the ENT team. My area is with the ENT upper airway caseload, and today we'll be talking about dysphagia and the role of the SLT in pediatric upper airway diagnoses. The agenda for today is to look at the nature of swallowing difficulties in the pediatric upper airway population, to look at some research findings and the role of the SLT in feeding and dysphagia for clinical and instrumental assessment. By the end of this presentation, I hope you'll have a better understanding of the swallow physiology and the impact of upper airway disorders on children's swallow and the role of the SLT. A safe swallow is where food or drink is propelled from the back of the mouth down to the esophagus. All of the food and drink should be cleared from the back of the mouth, and none should go down the trachea to the lungs, or this would be considered aspiration or choking. It's very important to note and keep in mind respiration when thinking about swallowing. As swallowing and respiration come hand in hand. If our respiration is disrupted, such as if a child has an upper airway obstruction, so is the coordination of our swallow. Therefore, breathing trumps our feeding. When you think about babies and infants, a complete and natural expiratory breath follows their suck and swallow to expel and clear any unwanted material from the airway. It's important to keep in mind with our upper airway ENT population that airway obstruction or limitations can impact on respiration and therefore impact on the coordination of the swallow physiology. What is dysphagia? Dysphagia is the medical term for swallowing difficulties. Some people with dysphagia have problems swallowing certain foods or liquids, while others can't swallow at all. Over time, dysphagia can cause symptoms such as weight loss and repeated chest infections. When we think of choking and aspiration, we often think of the obvious signs, such as coughing or choking, spluttering, gagging or not breathing, and wheezing, distress and color change. However, it's important to also think about all of those less obvious signs or subtle signs, such as eye watering or eye blinking. If a child has a bradycardia or desaturation or apneas during or after they're feeding, they're fatiguing or having tracheal tug, and they're having increased saliva or tracheal secretions, a gurgly or wet voice, a look of panic even, or stress cues such as eyebrow raises or even hands splayed or stop sign hands during feeding. Keep in mind with our upper airway population, these children have a much higher risk of silent aspiration. So even if a child appears to be doing well, swallowing overtly, this may not always be the case for those more at risk of silent aspiration, such as a child with a vocal cord palsy, for example. There are 3 stages of the swallow, including the oral, pharyngeal, and esophageal phases. Some common swallowing difficulties along different points of the swallow can include during the oral stage. A child might have difficulty if the lips are not able to close firmly. This may be impacted by low tone, and a child may have difficulty with keeping food or liquid in the mouth. Same with babies and infants with feeding. If the tongue is unable to move around the mouth and have good range of motion and strength, a child may have difficulties with their biting and chewing. Think about how difficult it would be to eat and swallow and even drink if you weren't able to close your lips or move your tongue around your mouth for swallowing and chewing. During the pharyngeal stage, if the airway to your lungs is not closed off tightly, food or liquid may accidentally spill into the lungs. This is referred to as aspiration. An extended amount of aspiration can cause a lung infection, such as pneumonia. If the muscles of the throat are unable to squeeze the bolus or food or liquid down into the esophagus, there may be food or liquid left over in the throat afterwards. This can also pose an aspiration risk if residue were to fall down into the airway after the swallow. With our upper airway population, it's important to understand that the child's current airway history, as well as if they've had or are planning to have any airway surgeries, as this may have an impact on the swallow physiology. During the esophageal stage, if the muscles at the top of the esophagus are weak, food may come back up from the esophagus to the throat, and this will cause them to remain in the throat after the swallow. If the muscles at the bottom of the esophagus are weak, food may come back up from the stomach, and this can create pain in the chest or a bad acidic taste in the mouth. And imagine for a child, this can impact their feeding greatly. Some airway diagnoses that you may come across can include subglottic stenosis, tracheomalacia or laryngomalacia, laryngeal cleft or vocal cord palsies, tumors or subglottic web, laryngeal injuries or spasms. You may find severe neck or mouth injuries, obstructive sleep apnea, foreign body obstructions, and even lung difficulties and much more. With these diagnoses, a tracheostomy may also arise, which we will discuss later in the slides. It's important to note, to keep in mind, any surgical interventions that may be required to support some of these children, as these surgical interventions typically can have an impact on swallowing. It's really important to understand, if possible, the swallowing presentation of the child before and after a surgical procedure, if this can be planned. Next, we will briefly touch on some upper airway diagnoses, which may require surgical intervention. I may go through these next slides briefly, but it's mainly just to give you an understanding of potential interventions that your surgical team might feel appropriate for some different diagnoses. With laryngomalacia, your ENT and medical team may find in certain cases that they're wanting to wait for growth with the child and monitor, or they may feel an epiglotoplasty or aryepiglotoplasty is appropriate for the child. They may even require a tracheostomy. For laryngeal cleft, your surgical team may feel that a conservative management approach is appropriate, or they may feel the need for surgical intervention. This may depend on the type of cleft and various other factors, but that's why it's so important to work closely with your medical team to understand what their plan is going to be and how we as speech therapists can help in relation to the swallowing. A child may have a subglottic stenosis, and your team may feel, for example, that a balloon dilatation may be needed, or a cricoid split, or a laryngotracheal reconstruction, or LTR. And again, these are quite large procedures, which can alter and impact the swallow physiology for our children. So it's really important to understand that full history, and if any of these surgeries have already happened in their history, or if they're planning on happening. For vocal cord palsy, your ENT team and medical team may find that they want to review over time. The child, in some cases, may require tracheostomy, or there may even look at augmentation or retinoidectomy. As discussed previously, some of the structural deficits that you might see with the children that you work with could be cleft palate, laryngomalacia, and tracheostomy, to name a few. Here are some images again to show you how these can change the airway. How many children and young people are affected by dysphagia? Between 25 and 45% of a typically developing pediatric population, between 31 and 99% of children with cerebral palsy, and between 26.8 and 40% of infants born prematurely. All ages can be affected by dysphagia. This includes the neonatal unit with prematurity, respiratory issues such as Pierre-Robin sequence, gastroenterology issues like tube weaning, cardiac babies post-surgery with vocal cord palsy, neurological issues, TBI brain tumor, and children with tracheostomies. Keep in mind, if a child requires a tracheostomy, they're going to require an assessment following the tracheostomy placement and before starting any oral intake. We see children across many settings at Evelina, and I'm sure many settings across whichever settings you're in the audience. If you're in a hospital, you may see children on a cardiac unit or in outpatient clinics. You may have a saliva control clinic or a video fluoroscopy unit. Children on PICU we may see if they've had post-extubation dysphagia, for example. We work with many respiratory children and many children with coexisting morbidities as well. The list goes on and on. Some recent research findings. There was a retrospective study in NICU in Rio de Janeiro, which composed of 18 newborns with bronchopulmonary dysplasia, while a second group was composed of 18 healthy newborns born between 29 and 32 weeks. In this study, it found that premature infants with chronic lung disease took longer to transition to oral feeding, were more sleepy during feeds, and showed signs of respiratory distress. Another study in 2011 showed that silent aspiration was more likely in a neurological population. And another study noted that post-intubation dysphagia was observed in 29% of pediatric patients. For every hour of intubation, odds increased by 1.7%, and the age over over 25 months increased odds more than twofold. There was a retrospective study over 10-year period at Our Lady's Children's Hospital Crumlin, looking at data for children presenting with reported feeding difficulties and recurring lower respiratory tract infections. 29% of these children had normal clinical feeding assessments. So keep in mind, no signs of aspiration or difficulty. However, all of these children, which were 17 in total, had an abnormal video fluoroscopy. So that 70% of these kids were having aspiration, and 29% were having significant penetration events. However, none of these children had difficulty with the oral phase of their swallow, and all aspiration events were silent. That's really important to keep in mind, that all of these children in this study had silent aspiration. So they weren't coughing or showing any other signs indicative of aspiration, which is really important in the role of the video fluoroscopy and journal. The impacts of dysphagia, some more research findings on the effects of aspiration in the lungs. This is a great topic to discuss on the impact that aspiration can have on our lungs and long-term lung health. We know aspiration can lead to respiratory complications. Some of these complications can include risk of hospitalization, lower respiratory chest infections, and even pneumonias. Well, in the effect of aspiration on the lungs from Wallace et al. In 2012, noted it's important to keep in mind the acidity and microbial content, as alkaline saliva contains oral bacteria flora, and in vulnerable children with neurodevelopmental delay, poor oral and dental hygiene can result in an increased risk of aspiration pneumonia with anaerobic organisms. The volume and type of aspirated material is also important to keep in mind regarding aspiration and the impact on lung health. Large volumes of aspiration, which was identified as more than 0.8 ml per kg, are associated with rapid and acute hypoxia. Small volume aspirations, such as microaspirations, may cause a more chronic and insidious presentation and impact on more distal lung structures. However, it still is impacting on the lung structures. With silent aspiration, as we know, this can be an increase in our airway population. Silent aspiration can result in chronic damage, with features of bronchiectasis, bronchiolicasis, and interstitial changes. Aspiration of a microscopic solid matter will result in acute hypoxia with airway obstruction that will cause sudden death, partial lung collapse if the obstruction is complete, or a ball valve effect with distal air trapping. Vegetable matter may induce a delayed but exaggerated inflammatory response. And finally, aerosolized liquid particles may produce a hypoxic response or generate a chronic inflammatory reaction as far distally as the terminal airways with a reduction in surfunctant protein levels. Let all of that soak in for a moment. It's quite a lot there, but it shows how important it is to monitor and understand the impacts that aspiration can have on children's lung health. It's also important to keep in mind coexisting pathologies, such as, for example, cystic fibrosis, asthma, chronic lung disease, as these can alter the effects of aspiration. A blunt host response to keep in mind to these normal aspiration events that can result in our swallow in pulmonary manifestations. Some examples could be neurodisability with ineffective cough protection, for example, cystic fibrosis with an abnormal clearance, immunodeficiency, and prematurity. So overall, it's important to note these impacts to long-term lung health in regards to aspiration, either large or small amounts. Let's talk a little bit about tracheostomy in specific reasons for pediatric tracheostomy. If a child requires a trache, they may need this because they have an upper airway obstruction, to clean and remove secretions from the airway, or for need of long-term ventilation. Some immediate impacts of a tracheostomy include altered airflow, decreased vocalization, and decreased intraoral sensations. This image is really useful. As you can see, the tracheostomy is placed below the airway where the vocal cords are. So imagine if air is redirected to not pass through those vocal cords, we're not going to be able to get voice very well. Some longer-term effects of a tracheostomy could include delayed speech and language development, altered interaction patterns with others and passivity, some behavioral problems associated with frustration and hospitalizations, some altered intelligibility, and an impact on voice and speech, including post-decannulation difficulties with speech and voice. The physiological perspective on communication with tracheostomy can include the impact on voice for dysphonia and aphonia, impact on speech for phonetics and phonological difficulties, and even auditory and kinesthetic feedback changes. With a tracheostomy, you may encounter early complications such as dislodgement of the tube, obstruction of the tube, or infection and bleeding. Some later complications could include granulation development, suprastomal collapse, chest infections and dysphagia, dysphonia, and even behavioral and psychological difficulties. Some recent research on tracheostomy. In a study from Rosing and Peak in 1999, it showed a high incidence of swallowing difficulties in infants with tracheostomy. Another study in 2000 showed differences in swallow function were observed on video fluoroscopy between patients with and without tracheostomy. Some of these swallowing differences included taking more time to close the airway, limited airway closure due to reduced superior movement of the larynx, or delayed swallowing initiation. However, not all children with tracheostomies will have problems with feeding and swallowing. Remember, the reason why a child receives the tracheostomy is very important. It's important to remember that feeding and swallowing difficulties may be related to the child's comorbidities and other factors not just related to the tracheostomy. For example, long-term non-oral feeding, hospitalization experiences, or even reflux and GORD. On an instrumental swallowing assessment, when aspiration was present in a study, 93.3%, which was 14 out of 15 times, it was silent with the absence of any cough response, which brings us back to that general discussion of our airway children having an increased risk of silent aspiration, and keeping in mind that this is very much present across this population, and keeping that in mind in your assessments given their history and background. And it also shows that there was an expressive language delay noted across research and also from clinical experience due to significant impacts on voicing. Some possible negative implications of tracheostomy on feeding include neurophysiological, mechanical, behavioral, and sensory. However, in some cases, the tracheostomy can have a positive influence on feeding. For example, a child may have severe difficulties coordinating their breathing before their tracheostomy. However, once they receive their tracheostomy, they may be able to coordinate their breathing better, which then can help coordinate their swallow physiology and their overall swallow function. Neurophysiologically, you may find that the desensitization of the larynx due to a diverted airflow is present in our children with tracheostomies. This can lead to silent aspiration. These children may experience altered coordination of the swallow, so coordination of glottic closure with bolus transit. They may experience altered expiratory airflow for clearing residue from the hypopharynx and reduced taste and smell. Keep in mind, altered humidification of inhaled air can also result in increased secretion production and risk of chest infection. Mechanical implications of a cuffed tube. There's quite a lot to discuss here. There are several reasons that an inflated cuff does not prevent aspiration. The physical presence of the cuff will reduce the potential that material will immediately contaminate the trachea if it enters the larynx and penetrates below the level of the vocal cords. As you can see in the image here, aspirated material is pulling on top of the inflated cuff. It's labeled food particles. When the cuff is eventually deflated, however, one can attempt to remove the material by tracheal suctioning. However, difficulties can arise when aspiration occurs, such as during a meal, when both saliva and aspirated food boluses may enter the airway, as cuffs are not designed to prevent larger volumes of aspiration. As most of you are aware, cuff pressure should be controlled and should remain below capillary pressures to maintain the integrity of the tracheal tissues. Therefore, a minimum leak often will exist, as the cuff walls should not seal tightly against the tracheal walls. Therefore, for the purpose of preventing aspiration, this means that material can actually fall down between the trachea and the cuff, especially as the cuff can slide with movement of the larynx. And bacteria can also easily move past the cuff into the airway, resulting in microaspirations. However, this is not typically present in children. Why might this be? This is because in children, in this pediatric population, we do not typically see cuff tubes. This is due to the small size of their larynx and fragility, as the cuff tubes have the potential of causing damage. However, this is really important to keep in mind with our children who do require cuff tubes, such as children that require ventilation or even long-term ventilation. Behaviorally, we find that negative experiences are more prone to happen in this population, as they have frequent tube changes and suctioning. They have prolonged hospitalizations and illnesses, gastroesophageal reflux, and aversion or hypersensitivity, as well as sensory dampened taste and smell due to reduced or no airflow through the pharynx, nose, and mouth. Remember the tracheostomy information when you're working with your trachea kids. The reason for the tracheostomy is really important. Why is that trachea there in the first place? Once you get that information and you're with the child, understanding their current trachea, what's their tube size, the make, if it's cuffed or cuffless, and have they had a recent MLB or assessment of their airway? Have they had previous or planned airway surgeries? How are their secretion management? Are they having frequent suctioning? If so, maybe why? Have they had previous decannulation attempts? And how's their humidification set up? The general rule is that oral feeding is not indicated with inflated cuff tubes, as we briefly touched on before. And as discussed, as inflated cuff tube is contradictory during feeding, we want to really work as an MDT. We want to establish the reason for the cuff inflation. Do they need the cuff for high pressure ventilation or chronic aspiration? You want to liaise with your medical team to query whether the child may tolerate periods of time with the cuff inflated. And through an MDT approach, we can discuss as a team progressing onto oral trials when appropriate, when a child is consistently tolerating cuff deflation for a fixed period of time. So our primary aim is to restore the expiratory airflow when we can with these children. Two ways to do this would be tube occlusion or one-way phonation valves. Tube occlusion is not something we generally promote others to do with children. However, I'm sure some of you have noticed if you've worked with tracheostomy children, that sometimes you'll find children will be chin tucking, or they'll even use their finger or their hand to try and close off the hub of their trachea. And what they're doing there is they're using their own compensatory strategy that they've developed on their own, usually, to redirect airflow so that they're no longer exhaling out of the tracheostomy where they're breathing in, but they're forcibly redirecting that air up and out their nose and mouth with either their hand, their finger, or their chin, and that's tube occlusion. We do promote, however, the use of one-way phonation valves. As you can see in this image, there is a one-way valve on the hub of that tracheostomy as well. They note it as a speaking valve. I'm using the term one-way phonation valve because the actual function and the mechanism of this valve is to redirect airflow, not necessarily be the reason we have speech and language. Valves don't come in different sizes. However, they come in different makes. Here are some examples of valves that we use at Evelina, including the Pasquier valve, which is the top right purple valve. And we also use voice line 2 valves, which as you can see come in all different colors. We used to use the Rush valve in the bottom left corner in the past. However, this valve is no longer manufactured, so we don't use that valve anymore. One-way valves, what are they and how do they work? A one-way valve is a valve which diverts airflow. So as you can see in this wonderful diagram, the child is inhaling through the tracheostomy. And as you can see, the one-way valve is secured on the trachea. So the way that the valve functions is there's a mechanism in the valve. Now, when a child breathes in, the valve will open and allow air to inhale into the lungs. It will enter and the child will inhale into the lungs. And then when they exhale, that valve will have automatically closed off like a little door, and air has to follow the path of least resistance. So since it cannot exit the way it came in through the tracheostomy, it's redirected up through the larynx and vocal cords out the nose and mouth. So imagine how important it is for this child to have a clear path for that air to exhale out through the nose and mouth without any obstruction or anything preventing air from going to the upper airway. One-way phonation valve fits on the 15 mm hub of a tracheostomy. That's why they don't come in different sizes. They're all the same make in that way. It's an accessory that fits on the tracheostomy hub instead of the HME or, for example, Swedish Gauze. This valve will restore phonation and expiratory airflow during the swallow and improve subglottic pressure generation, such as coughing, and might help to clear residue with that airflow out of the upper airway and can impact on smell and taste. With one-way phonation valves, it's really important to understand that every child requires a thorough assessment from a speech and language therapist, and ideally as an MDT with your ENT involved, as well as your ENT clinical nurse specialists, in order to determine if a trial of a valve is even appropriate. Eligibility for trial of a valve that we use at Evelina is to have a recent instrumental airway assessment, a microlaryngoscopy and bronchoscopy, or otherwise known as MLB, ideally within the last 3 months, because as we know with upper airway, sometimes our children's airways will change. So within the last 3 months gives us a good recent understanding of their airway patency. And we want their tracheostomy tube be at least 1 age bracket lower than their current age. We want to make sure they have an adequate upper airway patency as per their MLB results and their ENT consultants. And we need to ensure that they have a cuffless tube, and if it is cuffed, it is fully deflated with a risk sign up as well if you're working with children with cuffs to ensure anyone that's working with them that the cuff must be down if they're using a valve so that they can breathe. We also want to make sure that the child's tolerating time off their HMA. Benefits of a one-way phonation valve is that the valve can restore subglottic pressures, restore sensations, allows for rest of voice, and allows for improved speech production. It's also important to note that, at least in the UK, expertise in this field is required as postgraduate training for speech and language therapists. Here's an example of that chart I was talking about that can help guide you in age-appropriate tubes for a child and what one size below that would be for being ready for a valve. This is from the Paediatric Tracheostomy Tubes, recent developments, and our current practice paper in the Journal of Pharyngeology and Otology, which I recommend everyone go check out. A guide to the compatibility of airway diagnoses and conditions that may help with valve tolerance. Children that are more likely to tolerate a one-way valve could be children with mild to moderate subglottic stenosis, laryngeal cleft or vocal cord palsy, mild to moderate laryngotracheomalacia or chronic lung disease, neurological diagnoses, small subglottic mass, or deflated tight to shaft tubes. What all these children have in common, you may wonder, and may have already picked up, is that these children typically have more patent upper airways and less obstruction. So again, as we discussed earlier, the more patent and open your upper airway, the easier it will be for a child to breathe on a valve, because again, their exhaled air has to be able to exit up out the upper airway, because it's no longer able to leave the way it came in because that valve is shut off. Children in comparison that are less likely to tolerate could be children, for example, with aggressive papillomas, children with a severe subglottic stenosis or severe tracheomalacia or a laryngotracheomalacia, recurring granulation tissue. Something to keep in mind on this note is if a child has recurring granulations, they've had an MLB where they had a granuloma and it might have been removed, and if they haven't had a recent MLB to check, there is the potential that could have grown back. So you have to know their history on is this a problem for them or not, so you can keep close tabs on that so that we fully understand safety. If the child's medically unstable for medical instability, or they have severely reduced lung compliance, it'd be hard to breathe, if you can imagine, on a valve. If they have copious thick secretions, if they have an inflated cuff, or if they have a deflated foam cuff, again, because a deflated foam cuff will automatically re-inflate itself. So what is the role of the SLT in all of this, you might think? The SLTs, we assess and manage communication and feeding difficulties. We always work collaboratively with our multidisciplinary team. We strive to provide training to parents and other professionals, and we always approach each child individually and holistically, as we all do. For our SLT assessment, we want to look at case history, oral motor assessment, clinical dysphagia, the bedside clinical assessment, as well as instrumental assessments such as video fluoroscopy and Ps, communication assessment, and trialing strategies and interventions. When we are information gathering and looking at a case history, it's very important to discuss closely with your medical team and your MDT so that you're all on the same page about that child's history. We're looking at their birth history. For example, were they premature? They have a low birth weight, require ventilation. What's their medical ENT diagnoses and plan? We're looking at neurological, airway pathology, ENT diagnoses, gastrointestinal, cardiac, syndromic, structural, the list goes on and on for the things that you're looking at with these children. You want to make sure you have a thorough understanding of their history and their plans from the different MDTs involved. We want to look at their medications and their medical history. So with their medical history, you're looking at, have they been diagnosed? If so, what's their diagnoses? Do they have a vocal cord palsy or laryngomalacia? Have there been any surgeries to manage these diagnoses, or are there any planned surgeries? Have they been intubated? If so, for how long? And are they, or have they, or do they require ventilation? And if so, what are those settings? Medications, Avastin, sedatives, medications for secretion management. These are all really important things to keep in mind for your children. Have they had an MLB, a recent look at their airway? And if so, what were those findings? What's their feeding history? We're not only looking at their current feeding, but their whole history. You know, how did they feed at birth? How are they feeding currently? Have they had any long periods of meal by mouth? Have they had any tube feeding? Looking at their peculiar likes or dislikes. Some children with tracheostomies, for example, might have a preference for more strongly flavored foods due to their reduced sense of smell and taste. And you also want to look at additional factors like the child's appetite, their meal times. Are they even on a mealtime schedule? What's their environment like, and how's their vision and hearing? If they're a child with a tracheostomy, same thing. You want to know that tracheostomy status. How long have they had it? What's their current status with their tube? Have the length, is it a neo or a ped? And working closely with your respiratory team as well for if they need ventilation support. During the SLT assessment, it's really valid and really important to look at the oral motor assessment. We must not skip this step. We need to look at their oral reflexes based on their age and appropriateness. We need to look at their oral and facial structures. And we need to look at their oral movements in isolation as well as in sequence and their cranial nerves, as this all has an impact on their feeding and swallowing. Assessing if a child is even ready for a swallow assessment. That's a big part of our role as SLTs as well. Are they ready for us to go and assess their feeding and swallowing? We want to look at their medical status, their respiratory status, any ventilation settings they might be on, their neurological status, if they have any structural abnormalities, if they are any plans to correct those, if so, what's their feeding regime and nutrition like, how are they at rest, how's their arousal, respiratory state, what's their current oral intake and acceptance at this time, how's their secretions being managed, and how is their voice? You know, it's always important to hear their voice, because if they have a weak voice, you're going to want to talk to your ENT about if they think there's something going on with their vocal cords. If they have the tracheostomy, again, knowing if it's cuffed or not. During the clinical assessment, when we do our bedside assessment, we're looking at the environment and parent-child interaction. We're looking at the positioning of the baby or child, and we are then going to go and assess their current intake. So what's their current fluids and food textures? What are their delivery methods currently? Are they breastfeeding or bottle feeding? What kind of teats are they on? Are they using spoons and cups? Because we may need to change these if they're not working. We use tools such as pulse oximetry, cervical auscultation, green dye assessment in some cases for our tracheostomy population. We're looking for the clinical signs as well as the subtle signs of aspiration. And as we've on throughout this presentation, we're keeping in the back of our mind, given this child's medical history and their presentation, do we feel they might be at risk for silent aspiration? For example, again, vocal cord palsy is one where I'm always thinking that. We want to trial interventions and strategies. So does the child or baby need changes in their positioning? Do they need pacing to slow it down? Do they need changes in equipment? Sometimes they're just on the wrong bottle and you really need to look at if you need to modify the flow with the teat change, teat size changes. Do they need flow modification or adaptations to their food or fluid via ITSE? ITSE, if you haven't heard of it, is the International Dysphagia Diet Standardization Initiative. It's an internationally standardized descriptor of thickened fluids and modified diets for patients with swallowing difficulties. It's an ITSE framework, as you can see here. If you're interested in finding more about this, they have fabulous resources online on their ITSE website. This is really important to remain consistent in our recommendations, in our assessment of our fluid and solids in preparation and assessment. You may see ITSE used often on the wards or in children's feeding plans, in their notes or reports from speech and language therapy. Okay, to touch a little bit on this modified Evans blue dye test for aspiration. I think it's important to start off with saying that we only use this as a supplemental tool to our clinical assessment because of poor reliability, and there are factors to consider on whether it's appropriate at all to use, which we'll go over. We use green dye in the pediatric population. And the reason for this, as you may have guessed, is we typically don't like our children to have blue lips. If a blue tinge on the lips and mouth, this may falsely indicate hypoxia, and we don't want that. So green dye it is. And the method for this is we are adding the green dye to the food or fluid of choice, and we are suctioning the tracheostomy tube pre-feeding and then suctioning at regular intervals during the feeding. And then we also monitor the material post-assessment for evidence of green dye. In a study from Betty et al., we looked at simultaneous video fluoroscopy and dye testing in 20 subjects. They reported a 50% false negative error rate. So a negative result is that no green dye was seen on suction, and a positive result, meaning aspiration was present, is that green dye was seen. So in this, they reported that 50% false negative error rate, and that is dye testing identified greater than trace aspiration. So 10% or more of the bolus failed to identify trace aspiration. In a Parisi et al. Study, it looked at simultaneous VF and dye testing in 20 subjects, investigating effects of consistency. They concluded that positive results provided useful information, but negative results should be viewed cautiously. In an O'Neill study, it investigated 50 subjects using simultaneous video fluoroscopy with this blue dye assessment and found poor sensitivity and specificity. And what that means is the dye did not correctly identify approximately 20% of patients who were actually aspirating. So things to keep in mind. If you are going to use this assessment, it's also important to plan when you're going to suction, and that's dependent of the child and how they're feeding. You know, for young babies and infants, you may need to look at the first, after the first swallow, and then maybe waiting after a couple more swallows and suctioning, maybe waiting after 5 swallows and suctioning, and so on. And that just needs to be managed and decided at the time with your clinical experience. The limitations, however, to this assessment, as we discussed, there's false negative results as a risk. So even if you didn't see green dye, this doesn't necessarily mean that the child is not aspirated. It might have just been missed. And in some cases, there might have just not been enough green dye as well to fully see. So we need to keep in mind how much green dye you're putting in to get a result when they do aspirate. So you're not missing that. Only one texture can be assessed at a time, which is a limitation. So you pick one texture, and that's what you can assess. Because if you're doing multiple textures, you're not actually, when you see green dye, you won't be sure which texture is in that. You need support with nurses, the care or parents, because we don't advocate for SLTs to be suctioning in pediatrics. General stoma site as well as the suction support needs to be looked at. We need to use this and keep in mind this is a tool to use as an adjunct alongside other tools, not independent to other tools. And really, we have to manage those parent expectations. You want to make sure that the family's on board with the possibility that even if you do this assessment, you don't see green dye. It doesn't necessarily mean aspiration isn't present. So it needs to be carefully managed and given the risk of the false negative, and keeping all of these limitations in mind, it's not always appropriate. But it's something to keep in mind that different assessment approaches are dependent on the child and their individual situation. Reliability of a clinical assessment. Studies have shown that the cough is less reliable in the younger age group due to immature cough response. In infants, wet voice was significantly associated with aspiration on thin fluids. So keep in mind, if you're assessing a child clinically and they have wet, gurgly voice, they might be at risk for aspiration from what you're seeing there. Clinical examination has a negative predictive value of 89%, predictive penetration aspiration of liquids on but a positive predictive value of only 54%, and a positive predictive value for solids of only 18%. And silent aspiration is more likely in neurological populations. So things to think about with clinical assessment. Well, clinical assessments are always necessary. We always need to start out with a clinical assessment. You don't just jump to video fluoroscopy. It's things to think about because you need to use your clinical expertise and your assessment to determine if we need to progress on to an instrumental assessment such as a video fluoroscopy. Video fluoroscopy and instrumental assessment. So here's a clip of an example of a great clinician team with their lead vests on and a child in their tumble forward chair getting ready for their VF. Instrumental assessments for video fluoroscopy. What is a video fluoroscopic Telestudy? This study is a comprehensive evaluation of all three stages of the swallowing, so oral, pharyngeal, and a bit of the esophageal stage. It's a comprehensive eval. It includes the lip and tongue function, velopharyngeal closure, base of tongue retraction, hyolaryngeal elevation, pharyngeal contraction, upper esophageal sphincter function, and airway protection mechanism. So it looks at a whole lot of different things there in the swallow physiology. Because again, we're not going into VF with the goal of ticking a box if there's aspiration present or not. We're looking at the overall physiology and function of the swallow so that we can then put a plan in place to help the child with their swallowing. This assessment assesses a range of food and fluid consistencies. We're looking for the presence of and response to silent or overt aspiration. We're looking at the impact of therapeutic interventions on the swallow physiology, safety, and efficiency during the study. And the effect of fatigue as well. We can fatigue children in between screenings if we need to see if that impacts their swallow safety. The patient care and health professionals get good education with VF findings. The contribution to diagnostic profile overall in the context of a multidisciplinary assessment. So it's very valuable, and monitoring if the changes of dysphagia over time. So children, as you know, may require repeat VFs over time as well. Things to keep in mind with a VF, we want to consider the child's medical stability. If they're ventilated, is this portable? Their positioning, are they able to be in the right position for a VF? And compliance, always think compliance, will this child accept a VF, or do they have a history of refusal or severe aversion? If they're nil by mouth, why are they nil by mouth? For reasons other than dysphagia, are they aversive and refusing everything? Because a child like that, for example, you come in if they haven't eaten in months, and they're refusing everything, they are likely not going to accept during the study either. So clinicians and local clinicians also need to help children work towards being ready for a VF. And then also the representative, if the study representative of being able to give recommendations for the study, and the timing of the study. So have they just had a surgery, or is it right before a surgery, and making sure that you're doing your best to manage all of that. Now I'm going to show you a clip of a swallow study. So this is an example of a child with a vocal cord palsy who has a tracheostomy. And this is a clip of them accepting level 1 thickened fluids, which, as you can see, was aspirated. There we go. Yep, so we're going to see that one more time. Here they go, they're swallowing, swallowing. There you go, you can see the aspiration, they keep going. So with this child, since we saw aspiration, we were able to adjust the study and found that moving from level 1 thickened fluids from that ITSE chart that we talked about, ITSE level 1, that was aspirated, so we increased to, ended up on ITSE level 3, where no aspiration was present, and the swallow physiology was managed well with that change. Keeping in mind also, child had vocal cord palsy, so it was likely silent, and the benefits of going into a VF and seeing this and putting them on a safest plan, because clinically we are able to change the product for a child who's staying silently, because in a clinical assessment they may present as well, and as if they're doing well. So the importance of going to VF if needed. Another instrumental assessment would be the FEES, or fiber optic endoscopic evaluation of swallowing. Some indications for FEES could be assessing secretion management, assessing a patient at high risk of aspiration but unsafe for food trials. This allows us to assess breastfed infants. We can assess laryngopharyngeal sensations. We can assess the swallowing of these maybe specific foods. During this time, same as in VF, we can look at postures, strategies, and maneuvers. We can assess patients who cannot undergo VF for whatever reason, possibly if they're immobile or due to their equipment or medical instability. And we can assess swallow fatigue over time as well, and most likely do more repeated assessments, as there's no risk of radiation with this procedure. And we can also even use this FEES as a way to look at anatomy and physiology. In some cases, this can save an endoscopic procedure as well. So there's a lot of benefits here. At Evelina, we do not currently have a FEES service, but we are hoping to build a case for the service in the future. Things to keep in mind with FEES, there is a whiteout during the swallow, so you can see before and after the swallow, but not during. Compliance again, if you think about children and FEES, thinking about if the child's going to be able to tolerate having a camera up their nose and down their throat while they're being instructed to eat and drink. Are they medically stable? And keeping in mind our vulnerable populations, such as traumas to the nasal cavity within the last 6 weeks, facial abnormalities and such. I do have a video I'd like to show you on this, but due to the setup of this presentation and everyone in today, I'm going to exit out of the presentation and show you at the end. So please take a note that we will reroute to seeing an example of FEES at the end of this presentation. So with our overall assessment, speech and language therapists look to treat and manage for feeding and dysphagia, and some ways that we do that is through oral cares. Putting an oral care plan in place can be very important. Oral desensitization and simulation plans, developing oral motor skills as needed, changing position and pacing, and training and educating parents and people who will be feeding that child, looking at different utensils and bottles and cups, looking at different swallowing maneuvers such as chin tuck. For our tracheostomy patients, we may consider the benefits of a one-way phonation valve if they're appropriate for an assessment. We may look as an MDT on if a child can tolerate cuff deflation if they have a cuff and need a cuff. We're going to look at ITSE for texture modification, fluid modification, and we're going to be looking at if a child does need enteral feeding, such as nasogastric tube or gastrostomy, and if a child needs changes to the types of foods they're having, possibly needing changes in flavors or smells. So lots of different things that we can do as SLTs to help our patients. Overall, There are a range of conditions that we manage: congenital, acquired, varying locations, different dynamic or static effects of breathing, voice and feeding, and again, the list goes on and on. For tracheostomy, keep in mind that tracheostomy may cause aspiration or pharyngeal stage dysphagia, but primary diagnosis is much more likely to be the cause. So remembering why that child has a tracheostomy. Keeping in mind, a dye assessment for our tracheostomy population should only be used as an adjunct to other assessment tools if felt appropriate. A one-way phonation valve may be helpful in management for children with dysphagia, of course, as well as communication and voice. Always using our MDT multidisciplinary approach. Chat to your surgeons, chat to your ENTs, your respiratory consultants, your different fellows that you're working with, to your fellow SLPs and work together, trying to tertiary-based SLPs or local-based SLPs or school-based SLPs. It's important to collaborate together as well there for where that child is going, because they're not forever going to be in one place. And as well as your dietitians and your lovely clinical nurse specialists, such as your ENT, CNSs, or your long-term vet CNSs. They're all there to help you. We're all here to work together. So also remembering that risk of sound aspiration in this population, and that SLT assessment findings can contribute to decisions about surgical interventions. Surgical interventions can affect feeding and communication, so working together is best. Lastly, I would very much like to acknowledge our wonderful, wonderful team here at Evelina. We have an amazing group of ENT consultants, amazing ENT fellows, wonderful ENT clinical nurse specialists who I would not be able to do my job without, my fellow ENT SLT colleague, Lizzie Nash, and our wonderful patients and families, because that's why we're here, isn't it, to work together to help them. So this is the end of the presentation, as I've mentioned, but before we go on to questions, and by the way, here are references at the end, I'm going to end out and show you the video of that fees that I promised, and then we can open up for questions. Thank you for bearing with me through this presentation. I know it's a long one. So here we go. Just have to leave and stop sharing. Lily, you can probably put your mic on and just walk me through what you're seeing. Make sure that everyone can see you.
I can just see you at the moment.
Okay, I'm going to share my screen. And we're going to get up this fees. Here it is. Okay. Here we go. So here is an example of fees. Keep in mind, this is an adult. This is an adult's fees. So as you can imagine, there's not too many pediatric fees floating around on the internet. So I'm just going to play this and just have a look. So you can see that there's an eagle eye view. You're looking down at the larynx, there's the epiglottis. You see the vocal cords. They're swallowing right now. So as you can see before the swallow, and then they swallow. If he's going to swallow, there it is. And there's that whiteout I was talking about. So you're not seeing the actual swallow when it's happening in real time. There's a whiteout, but you see directly afterwards. So you can see he's doing a couple consecutive swallows. He's going swallow, swallow, swallow. And you can see that they've added color to this. I assume it's milk he's drinking. You can see a little bit of residue following the swallow. And there we go, he's talking a bit, which is always fun to see, those vocal cords. And from a fees, you can also see down into the airway. I'm gonna stop it here because they go into the esophagus and we don't need to see that. So, that's it for my presentation. I hope you learned something.
Brilliant, Rachel. Thank you so much. Thank you so much for that presentation. It's such a thorough presentation, so informative and engaging, and it's been really, really helpful and useful to learn so